So the topic today is really ensuring healthcare access, and really where do we go from here, and that is the question. So welcome to what's going to be, I think, a great conversation that certainly is timely around healthcare access, and we are pleased to be joined by this impressive group of thought leaders who will help us understand really what's going on and really where we need to pay attention. There are lots of moving pieces impacting how access and affordable health care, including the Affordable Care Act, known as Obamacare, and its potential repeal, the federal budget, and the state fiscal crisis. Christina was referring to something we all have been reading the last couple of weeks about the very real threat to our local community health centers facing as a result of the federal funding and inaction by Congress too. So I hope that we can get an update on that too, so you all can share really what's happening with our community health centers. So the topic of healthcare is not just timely, but it's very important to the foundation. And it's a special interest of mine as well as Christina's. Christina has history with Mary Wade, and she, before the foundation made her a generalist, she spent a long time in long-term health care, and I've been doing health care for over 30 years. But health in the foundation, health is one of the largest areas of grant making here at the foundation, comprising nearly about 25%, and that's $3.4 million of all of our grant making last year, and close to 1/3, about $930,000 of our discretionary grant making. So it's really important to us. We've also been home to the New Haven Healthy Star program for 20 years, and a few weeks ago we celebrated our anniversary. And this is a federally funded program that works to reduce and eliminate racial and ethnic health disparities in birth outcomes, which has certainly been influenced by access to health care for pregnant and parenting women. In fact, as a result of the recent state fiscal crisis and the cuts that were made to our local health department, our Healthy Start program had to step in to have our care coordinators trained to do Husky enrollment because of the cuts, the maternal child health division at the health department was completely wiped out. So there's certainly a lot of things happening right here in our city that's impacting all of us. And so again, we're really excited to host this particular briefing on healthcare access. And so again, I've acknowledged our panelists, and again, thank you all for being here. And each panelist will have 10 minutes to address a set of questions that they've been asked to prepare, and then I will follow up with questions, and then we also will open up for audience questions at the time. So if you have a notepad, feel free to write your questions there. If you have a burning question that just can't wait, then just let Ken know, and I'll be more than happy to pause for you, because we don't want anyone to kind of go crazy here. Again, our title is Healthcare Access, and where do we go from here? So before we discuss that, where do we go from here, I think it's important to understand, have a common understanding of how we got here in the first place. And so Francis, I'm going to start with you, and I'm just going to read these notes that were prepared for me, because I think they're the questions that you are asked to think about. But just for the audience's sake, so Francis, can you provide us with like a brief history and the policy backdrop for Affordable Health Care Act, and the kind of what we've gained, what are the weak points of the ACA, what is at stake with the potential repeal? ACA is not the only thing affecting healthcare access, so can you talk a little bit about how the state's fiscal crisis is affecting healthcare access as well?
So as far as the brief history and the policy backdrop, in 2010, there were about 50 million Americans without health insurance. And insurance companies were able to deny coverage on the basis of pre-existing conditions. And even if someone was employed and had health insurance offered by their employer, quite often the cost sharing of premiums and out-of-pocket expenses, co-pays and the like, would make it too expensive for them to be able to accept. So what the ACA tried to do was to really create a three-legged stool for insurance coverage. And the three stools involved insurance for people who are sick. And so there is where we get some of the rules that were created under the ACA to avoid people who are sick being discriminated against. It also recognized that through the law of large numbers, in order to mitigate risk in health insurance, one must have a lot of healthy people in the pool. And the insurance mandate came about because the insurance companies were being told that they would not be able to exclude anyone on the basis of pre-existing conditions. And they pushed back and said, then there has got to be a mandate that requires everybody to have insurance. And the employer mandate was tagged on to that. The third leg of the stool is that these health insurance marketplaces were created in order for individuals to be able to buy insurance on their own. And there you have individuals who are between jobs or self-employed or for some other reason need insurance in the individual market, which is not a market that health insurance companies actually find very profitable. And so in order to keep the premiums affordable, the ACA created the third leg, which was subsidies that are income-based to allow people to be able to buy insurance in this insurance marketplace as it's come to be known. In Connecticut, it is Access Health CT. We were the first state in the country to actually pass affirmative legislation saying we would create an exchange marketplace. And there are about 25 states that have their marketplaces run by the federal government. We do not, and that makes a difference. The other pieces of the ACA's backdrop is that one of them is the expansion of Medicaid. And through the ACA, states were being encouraged to expand eligibility for Medicaid from up to 138% of the federal poverty level. So that's roughly $60,000 a year for a family of four, $20,000 for an individual. And the federal government offered incentives to state governments, essentially increased reimbursement to state governments to be able to expand Medicaid. Lastly, that's fine. What's at stake if there is a repeal? And I'm going to jump ahead to that question because that's the opportunity for us all to see the picture as it appears here locally in our community. So in Connecticut, the uninsured rate in 2017 is now 3.5%, down from about 10 to 11% in 2010. And after the first enrollment period in 2014, it went down to 8% right away. So clearly there was some pent-up demand, and there has continued to be. Nearly 112,000 individuals are now covered with private insurance, and there are 672,000 people in the Medicaid program today. In 2014, almost 130,000 people in Connecticut became newly eligible for Medicaid as a result of the ACA, and more people have enrolled each year. What New Haven residents would lose, and I'm using New Haven as an example, but you can extrapolate a bit to other urban centers, and you can also just extrapolate to the greater New Haven area, because the ACA actually impacts a lot of people, okay? 119,000 New Haven residents have benefited. 9,000 residents who are under the age of 65 have gotten coverage through Access Health CT. And that, for New Haven, is an uninsured rate of 9%. It would be nearly twice as high without the ACA. It would be 17%. That's 11,000 people getting insurance through the insurance exchange, individual insurance. 47,000 residents of New Haven are in the Medicaid program, and 8,000 of those 47 are in it because of the expansion of eligibility under the ACA. 17,000 people in Connecticut, in New Haven rather, or 13% of our city's residents are in the Medicare program. These are people of all ages. And some people don't know that the ACA affected the Medicare program as well, in a positive way. 53,000 New Haven residents with employer-sponsored insurance. So any of us in the room who have our insurance through our employers also benefited from the protections of the ACA, which I'll say a little more about in a minute. I just want to give you a demographic profile. 64% live in working families, including 54% who are employed full-time. 77% are people of color, 73% have a high school diploma. Okay, that's our picture locally. And when you ask what's at stake, those people are at stake. Plus everybody else that lives in the greater New Haven area and in our state. So what have we gained? The ACA provides some safeguards and benefits for people with private insurance and Medicare. And I want to spend a minute just highlighting those because, again, a lot of people think it's all about the Medicaid program. It's important, the Medicaid expansion, but it's not the only part of the ACA. So for people with employer-sponsored coverage, ACA protects us from catastrophic medical costs because insurers can no longer limit lifetime benefits or annual coverage limits. Okay, so we have a board member at the foundation where I work who is a nurse midwife who tells me about babies born high risk premature, whose first 3 or 4 months of life cost $1 million. With lifetime limits or annual coverage limits, there they go. And those babies have pre-existing conditions. So later on, if there are any complications, in the world before the ACA, insurers could actually deny them. So we also got guaranteed coverage of preventive services, including checkups for babies, children, and adults. So this is cancer screenings, contraception, without copays or deductibles or other out-of-pocket costs. So those were cleared. Thirdly, if you lose your job, you can immediately go to the insurance exchange. Well, you have to wait until the enrollment period. That is true. You have to wait until the enrollment period, but you can get coverage through the insurance exchange, or if you're income eligible, you can actually go into the Medicaid program. So those are the protections for those of us who have employer-sponsored insurance. And then for people who buy in the individual market through the exchange, there are no more denials, I've already said that. There's a set of guaranteed essential health benefits that include mental health and substance abuse disorders, prescription drugs, and maternity care. And one of the challenges of repealing the ACA has been that the president has ensured that pre-existing exclusions would not be allowed. But the Congress has not been able to figure out how to make that happen. And one of the areas that would really, really suffer is mental health benefits and substance abuse benefits. And so it's caught up in a bit of a political volleyball, right, game among the Republicans. The other thing that's very important are these subsidies. The subsidies that were made available for people who need individual coverage in the exchange, but whose income doesn't really allow them to afford it. So the ACA actually gives money to the insurance companies to reduce the premiums, and that's what's called the cost-sharing reductions that are caught up right now in a lawsuit and politics. All right, keep track of time, guys. Improvements.
2 minutes.
2 minutes? All right, well, there are improvements to the public programs, the expansion of the Medicaid program, the coverage of medications in the so-called donut hole in Medicare. You can ask me about that later. And the weak spots of the ACA are the more insurers are leaving the marketplaces because the pool of enrollees is sicker because not enough young, healthy people went in. And some blame the individual mandate fine as not being sufficiently stringent on that. And of course, it's still the cost issue. Whoever asked about the cost before, cost and affordability are an underlying problem here that preceded the ACA and continue beyond it. There was a Supreme Court ruling that actually upheld the states that did not want to expand Medicaid, and so they did not. And then there's been an increase in high deductible plans by employers, which has shifted more of the cost of premiums and out-of-pocket expenses to people. So the average person who's working is feeling like they're paying more and getting less. The state's fiscal crisis, I don't need to tell you how bad it is, but what I will say is that as we forecast what could potentially happen, Connecticut could lose billions of dollars, particularly in Medicaid dollars, that it would not be able to replace, given the current situation, state of affairs. So that will equal loss of access. There's just no good news about that. It's also not only a fiscal crisis, it's a political impasse. So the same impasse that we have in Congress, we have here in Connecticut, more so since the November election than we have seen in past years. The state government could be doing better at controlling costs and regulating costs. And there are some initiatives around hospitals and pharmaceuticals, and there's payment reform work that's happening in Connecticut, but we have a long way to go, and there's political will that needs to be built for that. I'll stop there.
Okay.
Okay,
I think
and
that
you
you
can-
did a terrific job of really providing the backdrop for the ACA. I hope folks feel like they kind of have a good understanding.
I'm open to all
It
questions.
was
so-
great. And just to highlight, I think, because it was asked in the introduction, the concern about the mental health piece, and that's so critical
Yeah,
with
it is.
ACA. So again,
And
the
substance
impact
abuse
of not
treatment.
having, and
Mhm.
substance abuse treatment based
Yeah.
on what we've heard in the audience already. All right, so we definitely have questions later, but we're gonna go ahead and let the other folks introduce themselves if that's okay. And so Michael and David, to both of you, and Michael, you can answer first, but you are both working on the ground with people really impacted by federal policy shifts as well as the state's fiscal crisis. Can you tell us about the implications of all this on the people that you serve and their ability to access healthcare services that they need? And also, if you want to talk about implications on the employees as well. So if you want to start with that, and then we'll go into other questions.
May I, David?
Oh, I'm sorry, go ahead.
Let's start here. All of the things that Francis spoke to, and other factors as well, have created for organizations like mine great instability, financial instability. So I want to start by giving you a little context and a better understanding of what a community health center is. We are a nonprofit entity that is designated by the federal government, and that's why they call us federally qualified. That means a whole lot of different things, but what essentially it means is that one, the majority of our board members must be patients, okay? Must, by federal mandate. Two, it means that we receive malpractice insurance under the Federal Tort Claims Act, okay? So we don't have to pay malpractice premiums. Three, it means that how we're paid by Medicare and Medicaid is different than private practitioners. So we receive, as opposed to a private practitioner being able to bill for and be paid for every service they provide, our reimbursement for services rendered through Medicare and Medicaid beneficiaries is a bundled rate, wherein no matter what we provide an individual during an occasion of service comes back to us in a single payment. So unlike private practitioners, and those of you who are in the business, who stack what are called CPT codes, and that improves revenue to the organization, we can't do that. Our reimbursement is a single rate for services rendered to Medicare and Medicaid beneficiaries. The last part of significance, the significance of being a federally qualified health center is that we receive a grant from the federal government annually. And that grant enables what's typically called a sliding fee scale. That sliding fee scale allows us to subsidize the cost of care so that people who fall under 200% of the federal poverty level can be seen by one of our providers, all of whom are world-class providers, for as little as $20. So, with the four legs of that stool, let me then start to talk about how some of the things Francis has mentioned impacts an organization like ours. Prior to ACA being implemented, a greater proportion of our patients were uninsured, either uninsured for the many reasons that Francis talked about, including they had pre-existing conditions and they couldn't get coverage. Maybe their income was a little too high to qualify for Medicaid coverage. They are employed but can't afford the premium sharing shifted on to them by their employer. And so that means many of those individuals would come to us since we receive our federal grant. And the intent is that we can help people who are either uninsured or underinsured. So we use those grant monies to subsidize our cost of providing care so that we can see people for $20, okay? So, if ACA were repealed, and with it the Medicaid expansion went away, individuals whose family income exceeded 100 or was greater than 118% of the federal poverty level or exceeded the Medicare would no longer have coverage. And so for us, that means those individuals go back to being uninsured, which then means that we receive less reimbursement for the provision of services to those individuals, either through Medicaid or commercial insurance or Medicare, and we have to rely more on that federal grant to subsidize that cost of care. And oh, by the way, those grants have moved marginally in the past 30 years. So as the number of uninsured and underinsured people has increased prior to the implementation of ACA, we have had essentially the same amount of money for a very long time to subsidize care for people. So the elimination of ACA, and with it the elimination of the Medicaid expansion dollars, and the coverage for people who gain coverage via that expansion, becomes a real issue for us, because it means that all those people that Francis talked about who gain Medicaid coverage with ACA implementation since ACA was implemented in 2010 no longer have that coverage. Okay? Gone. Gone. So coverage gone for them, revenue gone for us. And they then move to become reliant on that grant that hasn't changed very much in 20 or 30 years. Obviously then, I think you would understand that that would put a great deal of financial pressure on an organization like ours, and in the instance of the Cornell Scott Hill Health Center, 85% of the 37,000 patients we see each year is covered by either Medicaid or Medicare. Okay? So when that coverage goes away, it has a very significant impact on our financial viability. And as a result, many organizations like mine struggled mightily before the implementation of ACA. And so it came to us with great relief and allowed us, one, to expand to see those additional people who rush to care when they gain coverage through ACA. And literally, I wish we could sort of go back in time and I could have some of you in the room sit with me as we enroll people for coverage under ACA and literally watch the tears flow from their faces. And people make comments like, I can finally have the operation that I've been putting off for 10 years. Okay? I can finally bring my child to a doctor as opposed to being forced to take them to a hospital ED and waiting all night to be seen. I mean, the stories of heartache, are just endless. And that's what we had prior to the implementation of ACA. So let's talk about other issues as it pertains to healthcare policy. One of the other areas of instability that is currently in existence is that grant that I talked about a little while ago. As of Sunday, it's gone. So, because the administration and Congress have been so busy trying to repeal and replace ACA since a change administration, they have paid no attention to the fact that health center funding expired as of September 30th, as in day before yesterday. And so as time progresses, now in our world, this is commonly called the health center funding cliff. We are now over the cliff. And there is no continuing resolution or reauthorization to replace that funding for community health centers. In my health center, we would lose 70%, as all other federally funded health centers would, of our federal monies. In my health center, that equates to in excess of $4 million every year. And also equates to our ability to treat 2,300 people every year. Because without that money, we can't enable those subsidies. There's simply nowhere to get the money.
Has that happened before, Michael? That you want to go, this program's gone over the cliff?
Yes. The health center movement was given comfort with implementation of ACA because we got 5-year funding guaranteed for our grants. What's being considered now, we'd love another 5 years. That doesn't seem to be in the offering. What's being considered now that we have gone over the cliff. And so organizations like mine and like Fairhaven Community Health Center and hundreds of others across the country will start to see a decline in our federal funds as we move beyond our current grant period and into the new fiscal year. And the money will just start to dwindle down until this cliff is fixed. What's being considered now, is a 2-year CHIME bill, which would reauthorize our funding for a period of 2 years. We haven't seen the details, and the devil is always in the details, always in the details. So we understand that, and I actually was on the phone today with some of our national folks in DC, and what I'm hearing is that they're very close to reaching a deal in Congress that would allow for additional funding. But pardon me, once burned, twice shy. And so I'm never comfortable until the deal is done. So what does this mean for us in practical terms? It means that on a daily basis, we don't have a stable financial future. Now, what does that mean practically? It means that on a daily basis, people who work for the health center, who provide the care that I talked about, routinely come to me and ask, is my job safe? And I can't give them an answer that gives them comfort. Okay? It means that if you have long-term debt that you are seeking to refinance, as we are, to access more favorable terms, the bankers who enable that debt said, nope, because your future's not stable. And so we're not sure, I'll put it differently, we are sure that until your cliff is resolved and your future is more stable, come back to us and talk to us then. Okay? It means that we really do need to think about, well, if this funding cliff isn't resolved, or if ACA is repealed and all of those people who gain coverage under ACA now lose that coverage, that puts additional pressure on us in addition to the funding cliff. And so it really greatly undermines our ability to certainly care for the number of people we do today, And quite honestly, if those things were to come to fruition in any real way, I can say to you with great certainty that we would simply no longer be able to care for 37,000 people, period. And that's just pure economics.
So,
Shall I go on?
if you can pause, because I think Francis laid a great foundation, and you really added some color to that by really taking us right to the impact on people and what you experienced there, and hearing from them as well as your staff. And so if we can shift to David, if you can kind of answer some of the same questions, because you're on the ground, you're with the folks, so if you can tell us how it's impacting your population and your staff.
Sure. We often don't hear about the senior population when we're talking about the Accountable Care Act. And I remember being in Washington, D.C. this past spring, actually on the Hill visiting our Congress folks. And this was the day before the first health bill was pulled back from the House of Representatives, if you remember that. And so I was in the heart of Washington reading all the newspapers, and nowhere in any of the articles when they were speaking about the repeal of ACA, did they discuss seniors when talking about Medicaid. And I think a lot of people aren't aware of the impact that a reduction in Medicaid will have on seniors living in nursing homes. You know, I've been in this field for about 40 years, maybe a little bit more, and I can still remember the days when people would take out second mortgages in order to pay for nursing home care, and so that their mother or their grandmother would not go on Medicaid. So that was a total different mindset than today, where, you know, attorneys are very skillful in helping people become indigent on a legal basis. And so it's just flipped. And so I thought I would give you, even though it was interesting to hear it at your level, I just thought it would be good for you to know how much is involved in Medicaid in the senior community.
And David, because it's a myth that most people think of Medicaid, they think of these women and children, poor women, but a large part of Medicaid dollars are spent in long-term care. So that's the big myth about it. So,
Yes. So Medicaid is a program designed to pay for those who are indigent, right? And it guarantees services to individuals who qualify. The states develop eligibility and qualifications to be on Medicaid. You can find those on any of the websites. And so as long as you meet that, you are eligible and you receive services. That's how it currently exists here in the state of Connecticut. There are several groups that are receiving funding from Medicaid. This is kind of interesting. 1 in 7 adults are on Medicaid. 2 in 5 children are on Medicaid. 1 in 5 people on Medicare have Medicaid. 3 in 5 people living in a nursing home are on Medicaid. And 2 in 5 people with disabilities are on Medicaid. This is interesting. Most of the people who are covered by Medicaid are children. 76% of the population covered by Medicaid are children, and 24% are seniors and people with disabilities. However, when it comes to the spending, it's reversed. 64% of the dollars go towards people, seniors and people with disabilities, versus 36% for children. The per capita amount funded by Medicaid to seniors is $13,300, opposed to the children, which is under $3,000 per child. The block grants now, when we talk about repealing the ACA, the portion that affects Medicaid has to do with language called the Medicaid block grant. The Medicaid block grant would then cap each state and would shift costs to the states, the beneficiaries, and the providers, and limit resources that would allow resources that would normally allow states to respond to crises such as the opioid crisis that we're currently being faced with. You might start hearing more and more the term long-term services and supports. So LTSS. Long-term services and supports would include skilled nursing homes, adult daycare programs, home care, home health aides, personal care, transportation, and family givers. Currently in the United States, the majority of people providing care to seniors are family members. Mostly a 50-year-old female that's running to and from a doctor's office visits and making sure groceries and medications are in the house. 1 in 3 people who turn 65 will end up in a nursing home. So, take account of this room. Medicaid is the primary payer source for funding more than 6 in 10 people. It's 62% of the population in nursing homes in the United States. Medicaid is the primary payer. In 2015, there were 15,583 skilled nursing centers in the country, approximately 1.7 million beds. Nonprofit, this is interesting, nonprofit skilled nursing facilities declined from 2009 to 2015 from 26% of the market to 24%. And currently there are 23.8% nonprofit skilled nursing centers. That's primarily because, on the other side, the proprietary nursing homes have increased. And that's primarily because many of the nonprofit nursing centers are like Mary Wade, who are in the urban environment serving a poor population. And those are the ones that have struggled through these last 10 years. National spending for long-term care services and supports was $156.8 billion in 2015. Much of the cost of skilled nursing centers is publicly financed. Nursing facility average annual cost is $82,000 in the United States. Here in Connecticut, it's $150,000. Nearly half, or 46% of residents that currently living in skilled nursing homes have a diagnosis of dementia. That means it's a challenging person to take care of. Distribution of certified skilled nursing facility residents by primary payer source is as follows. The United States, 61.6% are on Medicaid, 14.2% are on Medicare, and 24% are private or other long-term care insurance. In Connecticut, 69% are on Medicaid. It's higher than the national average. 13% are on Medicare and 18% are privately held. People who don't have a lot of experience yet with nursing homes and with their families think that Medicare is the primary source of payment when in actuality it isn't. It's only meant for rehabilitation, and that's changing through the ACA as well. At Mary Wade, about 85% of the people that we serve are on some sort of Medicaid program. We have skilled nursing, and we have an assisted living, it's a residential care home. We have transportation and adult day, and most of the population are covered by a particular type of Medicaid program. They're different types of buckets, but that's the population that we're serving. Now, on the other side, Medicare is also being affected by the ACA, and in the way of things that are called bundled payments, value-based reimbursement, readmission rates, and expansion of home care. So let me explain that a little bit. The Medicare and Medicaid are administered by the Centers for Medicare and Medicaid, CMS. And on the Medicare side, what they're trying to do is obviously reduce costs. And they've selected certain areas of illness, heart attacks, congestive heart failure, for example, is one. And this is called a bundled payment. And so CMS has been tracking the cost of caring for the people across the continuum from the hospital to the nursing home to home care. And their intent is to come up with a fee, a value-based fee for those illnesses, rather than the hospital being paid its daily rate with all the ancillary services that are involved, the nursing home, etc. They've been in the process of that for about 3 years now, and hospitals have been primarily dealing with that portion of it at this point. Now it's coming to the nursing homes, and they'll be looking at the cost that we are spending, those costs that we're spending in those areas. And the CMS is also looking at readmission rates. Why are people being readmitted in these bundled payment systems within 30 days? And they're penalizing hospitals currently for it, for a high rate of readmission in certain areas. So I remember my own dad, he ended up falling and after a hospital discharge, falling and having severe problems. Well, he was on a water pill that had one brand name. Well, he came out of the hospital had their own formularies. They gave him the same medication with a different brand name and never explained it to him. And he was pretty smart about his medications. He was pretty smart anyways. But so he was taking both, not knowing that.
Oh.
Not knowing. Now, he didn't end up back in the hospital, but those are some of the issues that are going on. The hospitals are using different formulas, not really explaining it upon discharge, assuming someone else would pick that up. And then that would be one reason why people are ending up back at the hospital. And then the expansion of home care. Well, currently, we used to get a 75-year-old person with a fractured hip, we would take for anywhere from 10 days to 30 days, depending on other issues, and go home. Currently, those are going straight home. They bypass the skilled nursing center altogether. The folks that skilled nursing centers are getting across the country are people with multiple comorbidities and older, much older, 85 to 95-year-olds. We've served people that are 100 years old on a short-term basis and sending them back home. But those are the folks, the more complex cases that we're seeing in the skilled nursing center. And across the country, occupancy rates in nursing homes are going down as a result of that. So as a result, people going right to home. And so it is eventual, I would say in the next year, on the Medicare side, that the hospital will send us a patient and tell us who the home care agency is. So the hospital contracts now with the nursing home and the home care agency all together. And it's one payment from CMS. So that's the effects that are having on our skilled nursing center. What is it doing to us? Well, Mary Wade, up until about 5 years ago, was a 60-bed skilled nursing center, and we did all long-term care. We admitted no one from the hospital. And the majority of people that lived with us were private, they could pay privately. And so we added new beds, and then all of this hit. And so now, there's a lot more reliability on the Medicare dollars and on long-term care insurance dollars, and on a Medicaid system that hasn't increased the Medicaid rates for the last 5 or 6 years. So we currently lose $100 a day for every Medicaid patient that is in the skilled nursing center. And so we are looking at dramatic changes in the protocols, the procedures that we use in taking care of the folks. And for staff that have been with us for quite a while, people that have been in the long-term care field for a long time, find it very challenging. And I think, with reduction, it's already been proven in numerous studies that a reduction in the cost of care in long-term care results in some really bad episodes for patients, such as open ulcers, major falls with major illnesses, just inability to take care of all the folks at the same time with a reduction in staff, which is usually what results in that. So that's what Mary Wade Home is facing. It's probably, I told Christina that it's been of all of my years at Mary Wade, 36, this has been the most challenging, the most difficult that I've ever had to face as a result of trying to navigate and get our ship able to sail through all of this myriad changes in the reimbursement system that's driving the way we take care of our folks.
Well, let me thank you all. Michael,
I just want just a point of clarification that I meant to make during my comments. But I think you need to have this understanding. I don't want to make any assumptions about the services that are provided at a federally qualified health center. For all intents and purposes, we are a primary care provider, but broader. So at the Cornell Scott Hill Health Center, we not only offer primary medical services, but we also offer dental and a broad range of medical specialties and subspecialties. And as well, we are a significant provider of behavioral health services, both mental health and substance abuse, inpatient and outpatient. So when people come to us, we then have the capacity to attend to all of their clinical needs, and so that we can restore and or maintain their health and keep them from the hospital. So that context, I think, is important for you guys to understand.
So thank you all again, and just as we're recapping, then let's get some questions from the folks there, but just to kind of give some math here. So we began right before 2010 with Francis. So at that time, many were uninsured in this country. We're talking about women, children, and seniors. Plus,
And
add,
men.
and men, add ACA, and we had more people insured, women, children, seniors, men, etc. So ACA equaled people were healthier and happier based on some of the personal.
Better access
Mm-hmm.
Yeah.
for many people.
Imperfect and a work in progress,
Mhm.
but
Mhm.
yes.
Okay, and now we're talking these newly insured folks, the women, the men, the children, the seniors, minus ACA. We're talking implosion of families and communities.
We're talking about a return to what was,
Okay.
And
if
maybe
not
worse.
worse, and maybe worse.
Yeah.
So chaos and the decline of health. So I
Yeah.
think you've laid it out very well, so thank you. So let's take some questions and get to some more. So Walt?
Question, what are the shortcomings in affordable health care? You didn't go into that, in which they're trying to rectify.
Well, I did mention that one of the problems with the marketplaces is that not enough healthy younger people have bought insurance. Even though we have an individual mandate where we're required to report on our income tax reform, on our income tax form each year, whether or not we were continuously covered, and if you answer no, you are subject to a fine. That fine is something in the order of $750. It could be more depending.
Which
I
was
don't know.
$95 the first year
Right.
after ACA was implemented. So
Right.
if you had a choice of paying insurance premiums or paying a
Yeah.
$95 tax penalty, what would you do?
Yeah, so people, people are economically rational, right? And so, excuse me, so the number of people who enrolled were significantly sicker, and there were fewer. And that has made it difficult for the insurance carriers to actually continue to provide products that are more affordable. I am not an apologist for the insurance companies though, because their rates, they submit rate requests to the Connecticut Department of Insurance every year, and they usually are in the order of, 25, 30, 40%. And there really isn't sufficient rationale for that. So there was that issue. The underlying cost of healthcare continues to be high. And as I listen to David describe the situation in the long-term care environment, particularly the relationship with the hospitals, it brings to me one of the problems that exists, which is that the hospital consolidation trend has really created a lot of this additional cost in the system. There is, so hospitals are now, they are owning doctors' practices, they are owning long-term care facilities, home health care agencies, they're owning it all. And
Insurance companies?
And insurance companies. And in part, they are doing so in order to adjust for the focus on value-based payment, right? So if we paid instead of on volume, right, and there are some cases in which paying fee for service on volume may make sense, but there are a lot of cases on which paying that way does not. If we paid on value, then hospitals would get less money. And the business model that hospitals are built on is a business model where they actually they have margin, even if they are nonprofit. And the question is, really, that one of the questions we've been looking at the foundation is, what's reasonable margin for a hospital? What is reasonable margin? If you're, okay, you are a capital intensive enterprise, you have to pay for good people, you have to stay current, we get that. But some of the margin that, you know, we question it. So some of the problems with the ACA have to do with the fact that the ACA doesn't actually deal with the underlying cost structure of healthcare. It tries to piece and patch together solutions to make care more affordable for people and still keep the same basic players in the, you know, in place.
So what kind of incentive
I'm
would there
sorry.
be for all of those players to come together to make fees more reasonable, where they could still have a profit, but the healthcare costs could be kept down? Because it seems to me that would be one of the arguments to support an ACA kind of plan.
So, short answer to your question, but it's very loaded. Is that the major players in healthcare, which are the hospitals, the pharmaceutical companies, and the insurance companies, need to be regulated. They need to be regulated. There will be no other incentive, and they need to be regulated in a robust way and in a synergistic and consistent way. And they have big lobbies. They have very big lobbies, and they resist that. So some of that can happen at the state level, and some of it has to happen at the federal level.
Never.
Well,
I must say that in all of the national dialogue that we have around controlling, better managing, suppressing increases in healthcare costs, I am astounded that in no part of that discussion is how we control pharmaceutical profits.
right.
Never even mentioned, because it's a political hot potato that nobody wants to touch.
Well, they have the most powerful lobbies.
Bingo.
I will say that that is gradually coming onto the radar of state legislatures. And state legislatures are trying, within their own purview, to do something to regulate pharmaceutical prices.
I hope we live that long.
Transparency and fair pricing, price gouging. So,
Okay, I think I, Matt, and then, is that Katie, did I see your hand? Is Katie
Well,
here?
one thing I've never understood is the insurance companies, to reclaim the money that they lose because of these rising costs, always come back to raise rates on the consumers. Why don't they ever go back to the hospital and say, you can't charge $10,000 for this radiology, or we know it costs $20,000 to get your knee replaced in one state, but only $15,000 in another. Why aren't the insurance companies going to the hospitals, the drug companies, and why aren't they? Isn't there an incentive for them to say, hey, don't charge so much, because then they get more money?
The typical response to your question is, from the insurance companies to the providers is, well, yeah, you can charge that, we're just not gonna pay you. But, so, how do you, as an insurance company, put yourself in their position? How do you do that when you're dealing with a provider organization, a vertically integrated hospital system that controls every aspect of the delivery system? What do you tell the members of your plan when that hospital system, who controls everything,
isn't
throughout the
in your
delivery
network.
system,
Isn't in your network.
I see.
controls everything?
So that
So do
means
you
some-
say, I won't do business with you anymore because your charges are too high? So then where do your members go? Where do they go?
So the hospitals and providers, are they just
They
making
don't.
up are they just making up these charges out of thin air? I mean, where do these charges come from for, you see these bills of when someone has
They're an accumulation of organizational overhead. my first job in healthcare was actually doing that stuff, so I know how
You
those
know how to
numbers are
do that.
built.
The charge master?
Yes, that was one of my first jobs in healthcare. I know how that works. And it's accumulation of overhead. And I would add that overhead in academic medical centers is extraordinarily high. It really is extraordinarily high. I'm not going to speak to the justification of all that cost, but I will tell you as a fact, it is very high.
We know.
Okay, you wanna get
And
to-
you see that reflected in your bills.
Well, I also see it reflected in this community with a large academic health center.
Yes, you do.
So I'm gonna get Katie, the other hand.
Wasn't there a mandate that that the insurance companies had to spend a set percentage
80,
on
20.
actual patient
Care.
care
Premiums, yeah.
over profit? And
Administrative.
if all this comes down, is that going away?
That would go away
It's
if
gone.
the ACA is repealed, and I actually think it's one of those things that the executive orders of the president have also weakened. So what that is that 80% of the healthcare dollar has to actually go to pay for healthcare as opposed to administrative expenses of the insurer. And when they exceed that ratio, they then have to pay consumers back. And we have in Connecticut the Office of the Healthcare Advocate, which is a guy named Ted Doolittle, and we recuperate through that office tens of millions of dollars every year. That go back to the consumer. They write a check and return
So
it to the
that would
consumer.
disappear if.
It would go away, yes.
Yeah.
So is there another question? Just wanna move to wrap it up. Cynthia?
During the Reagan era, there was a lot of block granting for community services of all kinds. We're not talking just healthcare.
Wasn't good.
You have touched on a small piece of what the block granting could mean if it were to be instituted again to a little piece of healthcare. Would you care to comment more widely on the dangers of block granting? I could see one possibility, which was at the time a point in, community centers for children versus elders
Well,
at that time. And what would you say about now?
So, we're currently under a Medicaid expansion program. If you're eligible, you qualify, you get funded. And so, with nursing home care, the state pays us, and they get 50% of what they pay us from the federal government. In addition to that, the legislature passed a number of years ago something that is, we call it provider tax, but they wouldn't let us call it a tax. So if you're on Medicare or private, paying privately, you're taxed an additional $21 a day, which we collect, pay quarterly to the state. They send it to the Fed somehow. It gets doubled and comes back, only it goes into the general fund.
It was supposed to go back to the.
It doesn't go to long-term care, it goes into the general fund.
And to the hospitals, that's it.
So now, with the Medicaid block grant in the new healthcare, if one passes, they'll base the contribution to the states based on what was paid the previous year. And they will then we're all going to be in Hartford fighting each other to
That's
get
exactly the
our
point I wanted
dollars.
to make,
So
is that it
everybody
sets
that's
all
on
the dollars against
Medicaid
each other.
is going to be fighting for our piece of our pie.
So, understand, and I love the terms that come out of Washington DC. They just fascinate me. But I want everyone to acknowledge and understand what block grant means. Block grant means funding cap. That means we're going to write a check for the services you provide that shall not exceed, under any circumstances, what we paid you last time. And perhaps less than some fraction of what we paid you historically. But when you hear the terms block grant, understand that means funding cap. That's what it really means.
Money that was coming to Connecticut will now go to other states.
Correct.
Right.
We'll lose in Connecticut.
So the estimate is $7 billion by 2026.
Right.
$7 billion.
That'll get repurposed into tax reform,
Right, to pay for.
tax cut.
I think what you could do, because I started to do this, is when you see your state representatives,
Yeah.
ask them what the impact of the Medicaid block grant will be.
Mhm.
They probably won't know, many of them won't know, but it'll make them think that they should know.
So I want to be honest with our time, keep you with that time. So there's definitely some more to talk about, but we just want to wrap it up. And I'm going to ask you guys, I'm going to say a couple of points, and then last, I would like you to have the last word. Just tell us, so what is your hope? Because this is going to be pretty dismal. But
That was
you're going to have a few moments just to say, so what is your hope moving forward?
Retirement.
And what can we do
Retirement.
in the audience,
Yes,
right?
and what we can do. But let me just say this, just to kind of wrap us up and kind of capture, because we talked about this cliff and being over the cliff because of decisions from Sunday. But, you know, I guess part of our challenge is how do we create a safety net as people are falling? How do we care for people? And then the second thing that comes up through this conversation is around policy. So as this people are over the cliff, is how do we begin to move people away from the cliff? So the policy work that you're alluding to. And then I think lastly, which really speaks to an opportunity to thank you all here as well as those in the room, and that is, in the meantime, what do we do? And I think this advocacy as leaders, advocacies and leader of the great organizations that you represent. So with that, I really want to thank them, because that advocacy that's coming from leaders in the health center world, leaders at the foundation, leaders at Mary Wade, I think our work is so important in this hour around advocacy. So again, caring for people, moving people away to our policy work, but the advocacy that leaders do and that many in the audience. So let's thank them once again for what they've given today. And then let's be eager to hear what is their hope. So if each of you just write down the line, just, so what is your hope, David?
That was the hardest part of the assignment. The hope is that as people get more educated, that you'll be able to get more engaged in policymaking. I think Americans have really become disengaged and ineffectual with government policy and bills. They could recite their favorite quarterback statistics going back 10 years, but they don't know who their congressman is, the name of their congressman is, or not to mention how they vote. And I think to get more educated, and as the population ages, we're going to need to get educated about the services that are available or not available to us. And so I think the hope would be more engagement by everyday Americans.
That's something for us to get engaged. Yeah.
I'm actually given hope by the fact that Congress hasn't been able to repeal the ACA has highlighted it's shown the fault lines in our system, our uniquely American system. And I think what that has done is that it's brought people who have been in favor of repeal of the ACA out to say, don't mess with my health care. I want no exclusions on pre-existing. Don't mess with my Medicare. And that's a moment in time. It's an opportunity. It has also brought out people who are very dissatisfied with the status quo, who haven't been out before. And we have some work that we're doing at the foundation, a campaign called Protect Our Care Connecticut, where these indivisible groups that have popped up, as I call it, right? Democracy Awakens, Democracy First. These are groups here in our state and around the country who are saying, wait a minute, there's something wrong with this picture in a big way. And it's not a policy problem, it's a political problem. And we have to work on it, doing the political advocacy and doing the electoral work. That electoral work doesn't happen here necessarily or by organizations like ours, but we can do a lot to engage people. I agree totally with David. We have to educate people, and we have to add about what's at stake and what's possible. A lot of people are asking about why we aren't looking at single payer. A lot of people are. Single payer, that's another forum. You can invite me back, we can talk about that. Because it's a whole nother ball of wax, really is. But the idea that we need a different system and that we have to figure out a way to get from here to there is really the moment. That's where we are right now. We're gonna have a lot of hardship if this Congress, because it's not just the president, it's the Congress, achieves everything that they are trying to do. But I am hopeful that they're not going to achieve it. The damage that they're going to do, we have to mitigate it. And one way that we can mitigate it locally is by making sure the ACA is still the law of the land. Make sure people enroll. Make sure people enroll. Make sure our state policymakers understand that rolling back Medicaid in order to balance the budget is not acceptable. We have to press really hard on those fronts.
Thank you. Michael?
It seems that the American public has become more engaged in the political process. Because first and foremost, I do think the vast majority of us really care about the welfare of others. Really, we're good people, most of us. But when you don't show up to participate in the political process, you are giving way to government by ideology rather than fact. And I think that's what we've all witnessed over the past year, or certainly a year or more. Government by ideology, not by fact. It's based upon what I, as an individual, believe the role of government should be, rather than the facts of how government plays out. So I hope we move more towards fact and away from ideology.
So with that, on behalf of Will, Christina, Dottie, and the entire foundation, thank you for being as panelists, and thank you all for joining us. Have a great evening, everyone.
Thank you for that.